there's so much that people don't understand about trauma, right? So what is trauma? What is complex trauma? What does it look like? I mean, just because some sort of traumatic event happened, does that mean that someone develops post-traumatic stress? The same, negative event can happen to two different people. One person can walk out traumatized. The other person cannot walk out with any sort of like clinical diagnosis or like long-term problem. So we're going to get into a lot. We'll talk about complex trauma. What is that? The treatments. But let's just get started. Sarah Burney, expert in all things psychological, but is particularly trauma and eating disorders. You guys can look at our last podcast. So let's start with, what is trauma?
It depends on where you're looking for the definition, right? So in the United States, right, we'll go off of the DSM, okay? And then the definition is just basically PTSD. But that also, like, doctors use the ICD-11, right, which is from the World Health Organization. That has trauma and also complex trauma, which the DSM does not have. Those are just like the diagnostic definitions, right, which I don't love, which I can explain why. There's a few different psychologists who I like the definitions from, but really what it is it's not the event that happened, right? It's the psychological or internal wound that we have as a result of what's happened. And that what's happened can be like a big extreme whatever, right? Which is what is required in the DSM diagnosis, right? You have to have had an extreme event. Or it can be a more, quote, little t trauma, which is, something smaller, objectively, according to all of these other definitions, smaller, like some type of abandonment. Or it could also be the absence of something important that we needed, especially as a child. So if I don't get acceptance and an ability to be like authentic as myself as a child, that in and of itself is quite often traumatizing.
Yeah, so let's start there. So the reason we're starting with the definition of trauma is, first of all, it's evolved over time. If you look at the DSM, which is the diagnostic manual that psychiatrists and all the mental health professionals use for criteria for diagnosis, and if you look at the history of post-traumatic stress, trauma first started with the definition being like witnessing or being victim to some sort of like major bodily harm. Now, classically, you see this in people that are like, war veterans. Over time, trauma, the definition has changed. And what Sarah said is exactly right. The post-traumatic stress, and as far as having the clinical disorder of whether it's complex PTSD or PTSD, it's not necessarily the event that happened. It's the mark and the injury that it makes on the individual. Now, Sarah also mentioned something else. So there's like this big T trauma that we use casually as far as like our lingo, with like, boom, one big major event totally overwhelms a person's ability to regulate and cope, leading to this like damage and change in our nervous system, this injury. And then there's like this quote unquote little t trauma, where over time, repeatedly, there is pain, psychological pain, typically physical pain, that changes our nervous system over time. Another thing you said that's quite astute that people don't hear about enough is trauma is not always about something that has happened to you, but can also be defined as something that has not happened to you, particularly when you need it most. The most classic example of this, of course, is like emotional neglect by, attachment figure or a parent. Now, as far as your practice, I mean, so how often are you seeing patients that have like quote unquote big T trauma versus little t trauma? And then we'll talk about more about the definition of complex trauma.
I mean, actually, there is actually a lot of overlap with eating disorders and a history of trauma. It's kind of like, I don't know, probably like 60, 70% have of the people that I see that have eating disorders have big T trauma histories. But what I would argue is that it's not even those big T traumas that have been necessarily the most significant, assuming that those didn't happen when they were like ages from birth till like 6 or so. What I would argue is that the reason that those trauma, big T traumas, were so significant is because they didn't have the like pre-existing level of almost like resilience and support that they would have needed in order to navigate those big T traumas in a like more effective manner, which I'm not saying is their fault, just to clarify.
Of course it's not.
And because it sounds like that if I'm saying like, in order to navigate this, you needed to have this, but you didn't. And anyone with a trauma history is going to be like, okay, so that's my fault that I didn't have that, right? It's just, we kind of have that narrative in general. We have that narrative of like, oh, it's my fault, right? Especially if you have a trauma history, because more often than not, inextricably linked to that is just like deep feelings of shame, right?
Yeah.
Which then leads to, this is all my fault. I'm like a bad or wrong person, whatever it may be. So, a lot of times this, like, if I already have a premise that I'm like bad or wrong or not good enough, right? Don't deserve to take up space. I have to like carry the weight of the world myself, you know, and like can't ask for help, right? And I like don't want to be a problem. Then when something happens to me, significant in the sense of like extremely like disturbing, right? Happens to me, then I'm not gonna feel like even like I have the right to reach out to various resources. I might not even have the resources to reach out to. Because if I did, then perhaps I wouldn't be in this situation where I have this like very like almost like broken sense of self.
Wow.
Right?
Yeah. Okay. So hugely important. So what I'm hearing here is, and it's absolutely true, the studies back this up, is one, the quality of the person, their character, their resilience. So the sort of like makeup of the individual matters as far as whether or not the trauma causes a chronic post-traumatic stress
Correct.
in the individual.
Yes.
So you can have two different individuals, and they actually did studies about this post 9/11.
Oh yeah, this is fascinating.
Where you find that one, people that, for instance, had like prior adverse childhood events, rather than people that didn't, were able to be more resilient, and there was less prevalence of development of post-traumatic stress, even though they were present in Manhattan and had the same trauma. And two, the support system that you have and how you are comforted and supported and validated and listened to and cared for also plays a significant role in whether someone develops post-traumatic stress. I'm sure, I mean, we're looking at probably similar literature, right? The psychiatric literature backs that up. I'm sure the psychological literature backs that up. But that's a very important point.
100%.
And it's not all about the event. It also matters about the person, their history, and their support system thereafter. Yeah.
What the literature said was that for kids that had the support that they needed at the time of the falling of the Twin Towers, right? They were able to make sense of the world in a way that was much more adaptive than for those kids that did not.
Yeah,
right.
Absolutely. And there's a completion of the arc here in these healthy individuals where through the support and through processing, that then could come to the completion of the arc in which they then return to safety and can predict that if something like this were to happen again, that I would be fine and I could act adaptively, and I've actually learned from this trauma, and here are ways in which I can keep myself safe.
Yes.
As we'll learn through our conversation today, those that have post-traumatic stress, they don't complete that arc. And not only that, they stay fixed in that sort of like fight or flight response, and they actually stay stuck in the past.
100%.
Hey guys, Dr. Mike Ma here, board certified psychiatrist. Now there is something wrong with the experience that I hear from a lot of patients when they see their psychiatrist. Psychiatrists are not taking enough time, they're not getting to know patients well enough, and they're not coming up with like a comprehensive plan that patients feel is individual to them, what they're going through, what they're suffering from, and what their goals are. I thankfully have been able to provide this level of holistic, comprehensive care in my self-pay cash business, where we have the luxury of taking the time to do things the right way. It's been a goal of mine to provide this type of care, this high-level, holistic, comprehensive care accessible through insurance. I'm thrilled to announce that I've opened a psychiatric group practice called Century City Psychiatry, where I've hand-selected some of the top mental health professionals who directly under my supervision are offering this level of care, but accessible through insurance. If you or anyone else you know is seeking psychiatric care in the state of California, visit www.centurycitypsychiatry.com. Thank you.
100%.
Yeah.
Yeah. Then so there's like the trauma is them staying stuck. It's like this wound that like they're stuck in, right? And this is where I think about the importance of self-compassion in healing trauma, which if we don't know how to have self-compassion, this brings in light the like importance of healthy interpersonal relationships. Because if I don't know how to have self-compassion, someone might need to teach me, right? But I'm not going to be able to look at the like heaviness and just like intensity and darkness of these wounds while not also having self-compassion. Then I'm just if I don't have that, then I'm just going to fall apart.
Yeah. And
right?
I suppose the follow-up question of that is, hey, doc, okay, you tell me, have self-compassion. Okay, I pat myself on the back. I say, Mike, it's okay. Okay, what the hell does that mean? Okay, yeah. How does one even develop? Like, what does that mean to have self-compassion? How do you develop self-compassion? Okay. It sounds good. Yeah, it sounds like, what is that? Okay. How do you do that?
I have so many thoughts. Okay. Well, first of all, a problem that happens is we can tell ourselves something all day and night. Oh, it's not your fault. Not my fault, right? And I can logically understand that. But another side effect of trauma, right, is that the left and the right, you know this better than me, the left and the right hemispheres don't communicate properly in a lot of ways, which means that the logic doesn't necessarily cross over to the emotional aspect. Or we can look at it as like the higher functioning in our like prefrontal cortex doesn't resonate down to the like our nervous system, right? Or anything that's happening in the limbic system, yeah. Right? So I can tell myself that all day and night, but it doesn't matter. That's basically what you're saying.
Exactly.
And so that is not self-compassion. That's just like a bunch of like drama that I'm telling myself to try to make myself feel better, but it won't work, as you said. Self-compassion has to actually come from starting to empathize, like really with ourselves. What I find can help build on it is think of, okay, if someone else were in this position, like had this experience, what might I say to them, right? Then at least we can come to the conclusion of how we might feel towards someone else in that position on our own, which is important for us to get there ourselves, as opposed to someone telling us like, don't you think you would feel this way? Like we have to walk to that place ourselves. Does that make sense?
Yeah.
So I'm like, if another kid went through this type of assault or abuse, how would I feel towards them? Yeah. Right? And what would I think about them? Then at least I'm starting to have like, okay, I can theorize what that compassion would look like. Okay. It's still going to be hard to apply it to myself, but at least I've gotten to the point of like, this is like actually what makes sense. And it's not this superficial, like, okay, like, you know, I'm a good artist. I'm good at this. Like, so I should be nice to myself. It's like a deep, like actually all of these things that happened, my way of responding to this was adaptive. It doesn't work anymore. Right? So if let's say if I'm assaulted or something and now I end up doing drugs, right? And I had no other support. Okay. Well, that was what I knew how to do at the time. That was not like the most adaptive response, but I don't have to hate myself for it. Yeah. Right.
And you're hitting on something critical here. And for the audience, adaptive means that we are adapting to the situation and behaving and protecting ourselves or attending in a way that serves us and is healthy and is not self-defeating or problematic or pathological. So we're healthily adapting to the situation. Now, I'm so happy that Sarah's here because part of our podcast that makes us special is we actually talk to the boots on the ground, the clinicians, the providers that are seeing patients on a daily basis. So a lot of the audience has asked several questions like, is it possible to heal and recover from post-traumatic stress? How do you do that? So we're going to get into how you treat as we move along the conversation today. But another thing I want to highlight that you said is that it's not always about the trauma. It's not always about how you were made to like feel during the trauma, whether it was violated, so on and so forth. But people often have feelings about how they themselves responded during the trauma, after the trauma. And in fact, a lot of them harbor a lot of shame, and a lot of the emotional distress comes from how they judge their own behaviors during a trauma. A classic example is a woman that's being like sexually assaulted and raped and blames herself for being completely frozen, right? Thereafter, you of course explain to her that there's fight, flight, or freeze. And, you know, you try to like educate as well. Or another classic example is of like the young child that was sexually abused by a major like figure in their life, but they relied on that figure. They kept trying to warm up to the figure because they depended on that figure and they loved that figure. And thereafter, when they're a little bit older or adults or even shortly thereafter, they have significant shame about how they did not stand up for themselves. They were not angry. They did not confront this person. And yet they still tried and maintained a loving relationship and sought after the affection of their abuser. So I really want to know about how you work with patients about, you know, with their trauma, but processing also has to do with how you feel about your own contribution or how you like, you know, behaved during and thereafter.
Okay. I'm going to go back one question before your last question.
Yeah.
So first, or I guess actually an unstated premise of your first question is that we actually can heal trauma, right? Now, I just want to like tease that apart a little bit.
Yeah, let's do that.
Okay. So I can't change the past.
No.
If you like punch me in the face, right? And it like somehow is like very traumatizing to me, I'm not going to be able to go back and rewrite history so that now you didn't punch me in the face. Okay. If the trauma, which by the way, this is how it's defined in the DSM anyway, or part of the definition, is the event itself, this is a problem because I can't change the event. So that's that.
Well,
right?
My caveat to that was perhaps some people's memories of the event is warped. And I don't know whether or not going back and reprocessing the memory to see if they have a warped memory of it. So perhaps you can't change the actual trauma, but perhaps you can reprocess and like look at the memory of the trauma, but I'll bring that in later. Yeah.
Okay, well, I'll respond to that. So then it's like, I guess what I would say is like the meaning I make about the event, right? But also I guess the narrative of the event too. And actually a lot of our memory of what trauma, the research also shows is our memory is like terrible. Forget about whether or not it's trauma, it's worse. But like we have it just like notoriously terrible memories. So whatever, if it's accurate or not, it's still my reality. Now I might be able to like reprocess and reframe some of it, but the idea that it's going to like disappear completely or change, right?
Got it. Yeah.
But the great news is since we're defining trauma as the injury as a result of an event, right? Big or little, or a series of events or lack of important things that we needed happening to us. The great news is I can work on an injury. Like if I have a sprained ankle, I can work that out. Right? So this is like very, very encouraging and empowering.
Absolutely.
On the other hand, that means that I have to do something, which is hard for two reasons. One, I have to do something. So, and I already feel frozen in the trauma or like numb to it and like dissociated from it. Right. Or like, I'm just way too overwhelmed to be able to like begin to navigate anything. And people often have like a learned helplessness. I can't do anything. Or a learned hopelessness. Even if I tried, nothing would work. Okay. They tend to go one of those two or both and flip flop in those directions. Also, if I think I can do something to heal, usually what happens is the next thought is, and therefore it's my fault that I'm in this position at all. Generally speaking, we think like, if I can fix something, this problem, when I'm fixing, is my fault. It's just like how we think, right? It's a much more mature perspective to think, listen, I have a sense of responsibility now. It's not my fault that I'm here. This is like, it's not that I have no influence perhaps at all, right? But it's a series of events that occurred, or especially if I'm a kid, like what level of responsibility do they have for many things? However, as an adult, I actually do have, if I choose to take it, a sense of responsibility over my own life and healing now. That does not at all mean that it's my fault that I'm here.
Of course.
But it's really hard. It's a more mature perspective to have hold both of those truths.
Yeah, you're exactly right. And you're talking about like this. So this is interesting, right? Because on one hand, it instills hope to know that there is something that I can do to heal. And on the other hand, it can be anxiety provoking to know that, oh my God, there is something I can do to heal. And now it's my responsibility to go do that. And that can paralyze people.
100%.
And the tenet of self-responsibility, I mean, that is one of the main tenets and pillars of building healthy self-esteem.
And this is very hard to have when you're very traumatized, because if I'm going to have like a healthy sense of self-responsibility, it's like, how am I supposed to get there if I already think I'm just like the worst person in the world and not deserving of anything?
Yeah.
Or on the other hand, the best person in the world, which like doesn't have to do anything. I'm super entitled, which is just a different version of still thinking that you're terrible.
Yeah. So, and this is why you need if you have the luxury of being able to have a clinician like, for instance, Sarah, to navigate this, because I mean, it's so nuanced, right? Yeah. On one hand, it is your responsibility to get better and find the resources in order to help you. But no, you shouldn't blame yourself for what's happened and what has continued to happen. And no, you shouldn't blame yourself for not coming to the conclusion or realization that it is your responsibility and that you can get better, having not thought about that earlier. I mean, there can be a lot of self-blame. Yeah. There can be a lot of shame. And a lot of avoidance.
Yeah. What you've described includes a lot of like dialectical thinking. Okay.
Which is what? What does that mean for the audience?
So I'm holding two seemingly opposing thoughts at once, right? And so this is also a much more mature way to think about things. And trauma does not operate from a place of like higher functioning, i.e. it's not as mature in its thought process, right? So it's very hard when we're in a trauma response, right? Which honestly might be how we function in the world in general. We might not even realize that the way that we like just exist in the world is as like a traumatized individual. Very, very high functioning people are like this. Also, obviously low functioning and everything in between. But being traumatized doesn't mean that I'm like having a panic attack all the time. That's a separate point, I guess.
Well, yeah. I mean, so I suppose the next question is, what is a trauma response?
There's so many options.
What does that mean?
So I forget exactly what it says. In complex PTSD in the ICD-11, it's like there's a disorganized like sense of self. I forget. We should look at what it says. But anyway, a trauma response can be dissociation. It can be numbing. It can be overactivation, right? It can be overactivation or underactivation, right? Basically what it means is I'm just not present right now, whether like it's whatever way it presents itself by me being like overactivated or underactivated. Basically, I'm just living in the past, stuck in the past.
Yeah.
Right?
Now this is a good time to kind of inject some education for the audience. So being traumatized and having a trauma response does not always look like panic and fear and anxiety. It can also look like the exact opposite of shutting down, being dissociated. So it's really important to know as a clinician when you're looking at a patient that just because they look subdued and they're not acutely panicking doesn't mean that they're not in a trauma response, one of which is dissociation. Now, a trauma response is usually secondary to a trigger. Now, a trigger can be anything. It can be something external, a scent, a sight, some sort of visual cue, something that you hear. It can be internal, some sort of memory or thought. And there is a trigger And then there is an involuntary response, this trauma response that can often look like overactivation and panic or dissociation. And what Sarah was saying is, and you know what? We'll get into the neuroanatomy of trauma shortly, because it does have to do with different parts of your brain, what's in charge, what is overriding what, and the limbic system is at the core of that. Okay, let's shift into how do we treat trauma? How do we treat post-traumatic stress, whether it's CPTSD, complex PTSD, or PTSD?
So as a clinician, the first thing I want to assess is where are we as it relates to like self-regulation, okay? Because what I want to prevent is flooding. What that means is like overactivation, or I guess underactivation of our nervous system. Because we have we'll call it, it's called the window of tolerance, right? So this is a window in which I can like be present and tolerate what's going on around me, okay? And the information that's coming in and like what's happening in my body. And so I think a huge piece that's missed in treatment is not being aware of this window of tolerance. And we're trying to treat someone, whether it be through, I'll define these in a second, through bottom-up processing techniques or top-down processing techniques. And we're not assessing for, are they even actually present right now? Like, AKA, are they able to actually process anything on a body, like systemic level or a cognitive level of what's going on, right? So that's like a very important thing to assess.
That's a great framework. So we're going to talk about self-regulation, but also critically important is recognizing what is a patient's window of tolerance. So what can they tolerate talking about before they are triggered into an automatic trauma response in which they either start panicking and having anxiety levels that is too high to work with in session, or when they then shut down and get dissociated.
Right.
Which means the dissociation is a defense mechanism.
Yeah.
It's how do I protect myself from this incredibly fearful state? And the way they do that, it's automatic. They're not choosing to do this, is they dissociate. They kind of, they feel like the world around them isn't real. They shut down. They feel disconnected from their body, and they're disconnected from the outside world. So identifying that window of tolerance as a clinician is hugely important.
Yeah, and there's also much lower levels of dissociation, just like kind of being spaced out. A lot of people would argue like some degree ADHD, right? That's a whole other debate.
Yeah.
But, and just like intellectualizing, right? I'm just trying to like distract from the reality and like actually being present, because if I'm present, it's very scary.
Yeah.
So this is the importance of, the clinician, two things. One, the clinician, I think it's their responsibility, at least at the beginning, to know what is going to be too much or too little for the client or patient. Because if the patient knew, then they would be doing it themselves, right? So it's on me as the clinician to be able to know, okay, this is pushing too far. I'm going to come back now and help them to regulate now. Or they actually need to go a little further. We're not doing anything here, right? If, people that are in a trauma response or been traumatized, generally have a very difficult time actually connecting to their bodies, right? Because it can be scary. Even if it's not like a physical or sexual trauma, it can still be scary because being present with how I feel is too much. Last time I was present with how I felt, these terrible things happened. Or at least one time that I was present with myself, these terrible things happened. So now I'm going to just dedicate my life to never doing that again.
Exactly. Now, and that's where the avoidance comes in. Right.
And we might not even know that that's the case. This can present as overworking, I guess also underworking, right? It can present in so many different ways. And this is why it's important to get a proper history, to just actually get to know where someone's at. And, frankly, just reading someone's diagnoses that they've gotten in the past is not indicative of really anything about them. And that's hoping that the diagnoses they got were correct. But, so all this to say, I think it's on the clinician or doctor to make sure that they have a feel for what is going to be in or out of the patient's window of tolerance.
Yeah. And to all of the audience watching that has their own trauma, perhaps even watching this podcast might be triggering. Avoidance is a classic technique or defense mechanism that patients that have been traumatized used because, like Sarah was saying, it's incredibly distressful being triggered because you get pulled back into the past. It's highly distressful and your body gets out of your control. Mm-hmm. So just even establishing care with a psychologist to delve into your post-traumatic stress is something that a lot of people avoid.
Totally.
So that is that's step one. In fact, like Sarah was saying, a lot of time is spent avoiding anything that could potentially trigger going into a trauma response because it is so distressful. People can engage in avoidance behavior in all sorts of ways. They can manically work, so they don't have any time. They stay incredibly distracted. They can turn to other self-defeating defense mechanisms like alcohol or drug use. So I must applaud, well, anyone that has post-traumatic stress that's listening to this, well done. But I really applaud those that develop the courage and have the will to seek professional help in the first place because you're going to start unpacking things that traditionally or historically you've been completely avoiding.
Yeah, absolutely. And it might not even be that we meet criteria for PTSD, but that doesn't mean that like trauma doesn't subtly run our lives, right? Whether it be like I'm quick to anger or I'm just like avoidant in general, or like how I am in like more codependent type relationships, all of these things. Yeah. Usually there's like a source of some type of like usually attachment trauma.
Yeah. And you're right. I get one of the big messages from today's podcast is that PTSD extends so far from the sort of textbook war veteran that is completely avoiding open spaces and big crowds because he's terrified of being triggered to fear for his safety. Right. It can affect you in much more subtle ways. And one thing that we're going to talk about a little bit later in the podcast is how it negatively impacts your ability to relate to other people, 100%. To have emotionally intimate relationships, whether that's friendships or romance. And that's often a very neglected that's an obvious, it's very neglected in treatment because trauma does impact your ability to relate to other people. Right. That can, unfortunately, a lot of times leave you feeling lonely and isolated, even if you're surrounded by people, right? Which
reinforces the beliefs we had from the trauma from the beginning, right? Really quick, while I think it's on the clinician to know the window of tolerance at the beginning, right? I also think that it's on the clinician to help teach their patients how to identify it for themselves.
Of course.
We also want them to be able to know, oh, this is like, why am I feeling this way? Like what's kind of going on? And then to regulate themselves.
And education is a huge piece of this. I mean, good therapy is giving the patient the skills to succeed without the therapist once the therapy is over. Yeah. So education is paramount. So somebody comes into you, and in most psychodynamic therapy, when you're talking about something that's emotionally triggering, you do want to identify the window of tolerance. Because if you're in session and you push the anxiety too high, then not enough work can be done. If there is no actual anxiety and the person's not activated at all, then probably not enough work can be done. You do want to get them inside the window of tolerance, and it takes an astute clinician to actually watch them, because you can literally watch a patient go and dissociate in session, and you have to know what to look for.
Yeah, and that doesn't mean we do it perfectly or anyone does it perfectly. You go out of it, you come back. You go and having compassion for yourself as the patient while that's happening, knowing how to move within that, like that in and of itself is so much of the work, because now what I'm doing is learning how to be able to be present with myself. And if I'm able to do that, now I can actually look at the trauma, if it is one event or a series of events, but I can actually look at the injury. And that is, how am I going to heal something if I can't even look at it?
So I suppose one of the main tenets of this treatment is just widening that window of tolerance. Now, I want you to kind of plug in the different modalities, especially EMDR, and explain to the audience what EMDR is. So if you could just continue this thought process as far as like your treatment, identifying the window of tolerance, educating the patient, and then where you go from there and how the different modalities fit in.
Sure. So EMDR, eye movement, desensitization, and reprocessing. Basically what's happening is we're trying to like unstick the memory, right? You don't even have to know the exact details of the memory, but unstick how it's like basically processed in your brain and move it from being like kind of stored in this more stuck place in the limbic system to being in a higher functioning in your like prefrontal cortex.
So that is going to confuse a lot of people.
Okay.
How do you unstick something? What is the so tell us more.
So what happens with EMDR is basically there's bilateral stimulation.
Bilateral, happening on both sides. With your what? With your eyes? Like what's happening here?
This happens with your eyes. It can happen with your ears. It can happen with like tactile. Some people do multiple at the same time. Originally, we started with your eyes, right? And you also have these negative cognitions and positive cognitions. So your negative belief and the positive belief that you want to get to. And throughout EMDR, throughout the treatment, you're regularly assessing for what level of distress you're at, right? And so the clinician doesn't like actually tell you and talk with you about something per se. You're like, actually, while this bilateral stimulation is happening, you're processing yourself, right? And just seeing, like going with it, right? And seeing where you land. And in doing that, what's happening is like we're creating a safer space for your brain to process whatever the trauma is. And also to go back even further from, let's say like I was abused 5 years ago, right? And I think that that's the main event. Well, then as I'm doing this treatment, it might be that I like kind of fall back into my brain naturally goes to remembering something from earlier and then something from earlier. And what can happen is I go from this narrative of like, I am broken to maybe the positive cognition of, well, you would do this work with the clinician ahead of time.
So for those who are wondering, okay, if I come, I see a clinician, they're doing EMDR, what? I'm going to sit there and they're engaged in some sort of like, what, tapping? Like explain, can you explain like literally what you have these people doing and how the bilateral stimulation, the stimulation on both sides has any sort of impact on your brain, or how does that do anything? Yeah.
So it's helping the right and the left hemisphere to communicate better, right? And what's happening is at the beginning of the session, you like identify how to help bring yourself to a safe place, right? So one of the main things in EMDR is a prerequisite before doing any of the deeper work, which is basically before diving into any of the actual trauma, is you practice using the bilateral stimulation, right? In a sense of like being able to, with safer and like easier topics, which allows for you to practice resourcing and coming back to yourself. Resourcing means coming back to yourself and being able to like ground and anchor yourself. Okay. And so what happens is you practice being able to do that at first, AKA practice being able to come back into a window of tolerance, a feeling of safety.
Which is self-regulation.
100%. And the clinician and you are assessing throughout what your distress level is, subjective units of distress.
Yeah,
right?
Fascinating.
And then, so after we establish that you're able to regulate yourself. If you're not able to do this, the EMDR is not for you. This is my opinion. Whatever. So
they're doing this tapping themselves. So if they find that they get outside of this window so they do it prior to being sort of like purposefully triggered to go outside of their window of tolerance.
Yes.
And preempting it with the tapping, then, make some sort of physiological change in your brain. And then at some point you push them outside of their window of tolerance purposefully, I imagine.
Yeah, they naturally actually kind of get there.
And then they exercise the ability of bringing themselves back into the window of tolerance.
Yeah.
And a byproduct of all of this is the window of tolerance is actually going to widen, right?
Yeah. And what happens is they're reprocessing the memories in the event in like a safer space. Yeah. Right? And at the beginning,
which is exposure therapy, kind of. Yeah.
Exactly.
Yeah.
Yeah. And you don't really have to do much. It naturally occurs. If I'm in a safe space, right, then I'm naturally going to have permission to kind of go wherever I need to go to reprocess. Our brain, we want to heal. Yeah. Of course. And so if we're able to create a safe enough space, then we'll do that.
Yeah. And it's important for everybody to know that the reason, the brain, the different sides of the brain, the left side and the right side, do have different functions, which is where this bilateral sort of technique is grounded in. For instance, when patients are having a flashback, The left side of their brain, there's a certain area called the Broca's area that is in charge of like speaking, of language, of like literally speaking out language. When someone's having a flashback, that part of their brain will have lower functioning. They've proven this, right? These are facts. That is why oftentimes you see people kind of like going mute when they're having a flashback. The right side of the brain, for instance, there's a Brodmann's area. That's that sort of like visual area that lights up when you first see something. So you have, and for instance, when someone's in a flashback, that part just lights up. So the different sides of the brain are doing different things. And when someone is in a trauma response, there's a dysregulation where one side shuts down, parts of one side shut down, parts of the other side light up. So here we're trying to kind of like
have them communicate
prime our
properly.
brain to be more functioning like in a normal way, rather than how it would typically do when you're sort of like sparked and triggered into a trauma response.
Yes.
So you're priming your brain to process things in a healthier way.
Yep.
So that you can do all these sort of like engage in like what Sarah's discussing to reach your goals. Now, first question. Well, another part of the brain that's deeply involved in this is your hippocampus, right? The part of your brain that like processes new memories. That is also quite dysregulated, which is why when someone's in a PTSD flashback, it literally feels like the trauma is again happening right now. You're stuck in the past. Part of trauma is being stuck in the past. Now, you mentioned fawning. What's fawning?
I guess an easier way to say is like people pleasing, right? Or I guess more simplified. That's what we see a lot. You know, you see, you can have a mix of responses. You might not only fawn. But if like, let's say I know if I act in the wrong way, like I'm going to be attacked as a kid, right? Or as an adult, whatever. I'm going to learn to like try to adapt and to please them, fawning over them. This is like, people might be like, why are you fawning over your abuser? Right? He's abusing you or she's abusing you, right? Because that's adaptive. Because I'm trying to make it so that they don't.
Exactly.
Right? And there's just so many.
And this fawning response, I mean, it's really prevalent in like the narcissistic like abuse literature as far as like fawning. This fawning is the source of a lot of shame that people have later. It's like I was fawning over my abuser.
Right.
Now, does someone need to look into the past in order to heal from PTSD and trauma? Is that a requirement?
Well, you're going to have to look at what your pain is. So you might not, let me just redefine what it means to look at the past. You don't have to know the memory exactly. Okay. But what we do have to know is like how we feel, right? And the reaction our body or we are having. And how am I supposed to heal something without like being able to be present with what's happening? I don't have to know the details of what led to this, right? If I do, great. If I don't, also okay, right? But I don't have to do that. But what I do have to do is be able to be willing to look at and then develop the ability to look at how I feel, right? And the meaning that I make like about myself in the world. I might not ever get to remember or know what it was that caused me to have these specific feelings or beliefs. It's nice in the sense of like, honestly, we feel like we have a little bit more control and like the world makes more sense to us if we know, oh, I'm having this reaction. I'm like terrified of intimacy because of X, Y, and Z. This is what happened to me. So this makes sense, right? But frankly, even that, like that might not even be the whole story. Regardless, you don't have to know what the X led to where I'm at today. All I have to know is this is where I'm at today, which is stuck in the past. Right?
Yeah.
And to have compassion for myself, not judging myself while I'm looking at that.
Can somebody successfully get treated for PTSD if they tell you, let's just look at how it's affecting me now? I do not want to talk about the prior trauma in my past at all.
I mean, I can't really, if you have a memory, if you're like, I guess I need more details in this question, but let's just like give a general example. So can you be more specific?
Well, there's some
with an
patients
example?
that say, listen, I don't want to talk about the past. The past is the past. If I talk about it, it's just going to give me all this stress. Doc, can we just talk about how it's affecting my life now? Go through examples in which perhaps it's impacting me now and focus on the present. I really don't want to spend any time talking about my prior trauma. I've tried it. All it causes me distress and it just puts me back. Can we just focus on how it's impacting me today? I don't even want to talk about the past.
So the way that it's impacting you today, right, is the fact that it's impacting you today means that it all the time is running the show like behind the scenes. Mm-hmm. Okay. So for me to pretend that that's not happening, that would just be ridiculous. Mm-hmm. You literally just told me that the past is currently running the show. It's impacting me today. Mm-hmm. But by the way, I would like to not speak about it at all. But I'm like, how can we not talk about how to fix today if you're telling me that what's happening today is exactly this from the past?
You're living in the past. In fact, that's a great time to discuss avoidance behavior. Now, is EMDR the only way? Is it the best way? What other sort of modalities, and are they all hinged on this sort of like building out the window of tolerance and learning how to self-regulate?
Okay, so there's like body and somatic informed interventions, right? And then there's more like cognitive informed interventions. I'll explain. So the body informed interventions are really ones like polyvagal theory interventions, regulating your nervous system, somatic experiencing interventions, right? So this is more that what I mentioned earlier, bottom up processing. So the bottom being the lower functioning parts of your brain, like the limbic system, right? Mm-hmm. Your fight, flight, or freeze response. So trauma interventions those are trauma interventions that start there, mm-hmm. right? Regulating our body so that we can even just like be present.
What are some examples of ways that people regulate their body?
I mean, the somatic experiencing interventions and the polyvagal theory interventions have a variety of ways, really, but even just taking a deep breath, mm-hmm. right? Yeah. And like actually being present while doing that. Mm-hmm. You know, you could use dialectical behavioral therapy skills, which are like much more simple to, I guess, Google, you know, taking a deep breath, like not distracting yourself with intellectualizing or working, literally just being present with yourself and not distracting.
Mm-hmm. Yeah.
Which freaks a lot of people out.
Of course it does.
You know? And so anyway, those are the like more body-centered, right? Yeah. Interventions. Now, then you also have interventions like CPT, cognitive processing therapy, narrative therapy. These are more top-down approaches, right? Mm-hmm. Which are you're kind of like rewriting narratives or making meaning of the trauma, mm-hmm. right? Or remaking meaning of the trauma, which is also extremely valuable and important. And, you know, I think a balance of both mm-hmm. is essential. What I think is noteworthy is that the narrative therapy and the CPT interventions will not be as effective, in my opinion, if you have not done more of the body and somatic work first. The reason for that is basically you could almost go the route of it ends up being more intellectualizing because now I can make sense of it. Now all these things happen. I have all these like, you know, great realizations, but they don't land. Kind of like you were like, if I have self-compassion, say nice things to myself, but it like doesn't go anywhere. Mm-hmm. Right. So I can have they're valuable. It's important. I can come to a cognitive understanding that this was not my fault. Mm-hmm. Right. Or that like, I actually felt very like abandoned in my childhood, even though my parents loved me more than anything in the world. Mm-hmm. Right. But they just didn't know how to love me and show up for me in the way that I needed. So I felt abandoned. And then I felt like I had to like be responsible for everything or overperform. And now I can't be myself because for myself, I won't be accepted. And so all of these, you can come up and make sense of the world. But if I don't have an ability to actually be present with myself, and then I can't let that sink in. Mm-hmm. So you really do need both ends, right? And this is where I really like parts work, internal family systems. Interventions obviously have a lot of parts work, and that is a little bit of like, there's kind of the body end and the cognitive end, and the cognitive end. Parts work means that I'm looking at different parts of myself, right? Like there's the protector, I'm not going to go into it, mm-hmm. right? But I'm seeing myself more as a whole internal system, mm-hmm. right?
Yeah.
Yeah.
At what point, as a psychologist that is treating PTSD and complex trauma, do you decide to send them to a psychiatrist to get evaluated for psychiatric medications?
I guess it depends on what their like actual symptoms in everyday life are, mm-hmm. right? Well, first of all, if they want to, then I give them referrals. So mm-hmm. that's number one. But also if they're presenting with like significant symptoms that interfere with their day-to-day life, then I'm going to say, listen, I don't know the answer to this. If there is anything that will be helpful, but I'll refer you, right? So if they're having symptoms like high levels of anxiety, levels of depression that are actually like debilitating, right? Can't regulate their mood, difficulty with sleep. The reality is, there's not going to be a pill. Like, you can speak to this better than me. Like with bipolar disorder, there's like a pill. This helps. This will literally, it'll like make it so that the chemicals in your brain fire properly. There is not a pill that you can take to make it so your trauma like no longer influences you. Okay, I guess technically there is. We could sedate you. Okay, great. But now it's not like I've healed it all. It's not like now I'm operating like at a optimal level. Now I'm just like a different version of avoidance. Maybe that's all. Maybe, okay. Like, all right, you could do that.
Yeah.
Right. But that's not that I've actually healed the trauma. It's that I'm just like, it's not coming up because I'm so numb.
Yeah. I suppose that might be kind of part of the like somatic therapy. Now, what I would say is, as a psychiatrist, there are certain medications that can be massively useful in treating post-traumatic stress disorder. The first one is prazosin. Now, prazosin works with your alpha receptors, and it blunts your alpha receptors and it blocks your alpha receptors. And it is fantastic for people that have flashbacks and nightmares, specifically nightmares. So what I have found is that this is one of the medications that I can prescribe to patients that's very well tolerated. They might get a little bit dizzy upon standing when they first start it, but it's a medication that can take before bed that can have fantastic results as far as reducing the frequency of nightmares. And nightmares are an interesting thing, like reliving phenomenon are an interesting thing, because people will spend so much time of their waking hours engaging in avoidance behaviors so they do not trigger a flashback or reliving experience. But when they're asleep, all of their defenses are kind of down, which is why the flashbacks are such a prevalent part of PTSD and so incredibly distressing. Now, some people will say, well, doc, I can't defend against that because I'll take a weed edible, I'll smoke a bunch of pot, I'll get drunk, I'll have a bunch of alcohol, and I will then dull my ability to dream. And that's my defense mechanism against having nightmares. So they're literally defending against the day when they're awake, and then they're defending against their nightmares when they're asleep.
Yep.
Prazosin is hugely helpful in that. SSRIs can also be incredibly useful in treating patients that have post-traumatic stress. Part of PTSD is, Sarah's talking about like, bottom up, top down, bottom up. So the kind of like middle of your brain has something called the amygdala. That is the fear part of the brain that picks up threat and then activates the rest of your body to respond to threat, right? It'll tickle your hypothalamus, it'll tickle your pituitary, your adrenals, you'll release adrenaline, your stress hormones, your cortisol. So the amygdala is intimately involved in the pathology of PTSD. And for instance, they have all the literature in the world that shows that increasing the amount of serotonin that's available in your brain can work on your amygdala to make it so it's not as reactive to a trigger, thus diminishing a hypervigilance, thus diminishing some of the reactivity that you find in PTSD. Not only that, PTSD, there's symptom clusters, right? There's a vigilance, right? There's a hyper arousal to threat. My radar of threat is so sensitive that I'm going to pick up a ton of false positives, but I'll never miss anything. And I will ignore safety signals, right? There's flashbacks, there's nightmares, there's reliving phenomenon, there's avoidance of any situation that could potentially trigger a flashback or also put you in the same sort of threat. And there's also a mood disorder that comes along with PTSD, whether it's irritability, depression, or both, which is why as a clinician, you really need to make sure that you're not calling someone clinically majorly depressed when it's actually a mood disorder that is part of PTSD. So SSRIs can work wonderfully. Prazosin can work wonderfully. Sleeping medications can work wonderfully. sometimes giving somebody a benzodiazepine like a Xanax or something for a time-limited period can work wonderfully. So there's absolutely a big time role for pharmacology in treating patients that have post-traumatic stress.
And sometimes it's like, okay, we want to help them to be able to operate within this window of tolerance. And so they might need help for right now. Like when you're like recovering from an injury, if you need a brace, okay, then ultimately we don't need the brace anymore, but I might need it for a little bit. No shame or problem with that. It's really when it's just like, I don't want to do anything. And I'm just going to try to use this to like check this off the list. And because we can't get around this like responsibility that we have.
Well, you know, on that note, these medications, although they can be extremely helpful, can then, if the patient is not actually attending to the trauma, can just facilitate an avoidance behavior. Right.
Like
so the prazosin is just a pharmaceutical version of the alcohol, and the SSRI is just promoting the ability to engage in defending yourself in, you know, in your waking hours. So it's critical, and that might be better than nothing.
Right.
Listen, a lot of people cannot afford or have the time or have the access to see therapists and do that sort of deep work. So of course that can be better than nothing. But in the ideal situation, and in most of psychiatry, it's meds with therapy. They work in concert. So you do not want to let the medications enable any sort of like avoidance if you can help it. And you want to enable them to be able to like perhaps even build a window of tolerance so that they can enter therapy and engage meaningfully.
Exactly. Yep.
Let's lean back into complex trauma, CPTSD. I imagine in the next version of the DSM, it'll be recognized. So let's revisit that again. What is complex trauma? How does it develop? Is it always secondary to your attachment figures like your parents that raise you? Can it develop outside of that? Can people have like perfect parents that did a fantastic job and still develop that later in their life? How does it present? And how does it negatively impact their ability to relate to other people?
Well, there is a technical definition of complex PTSD, which we could look at in a second. My opinion is that it is not possible to grow up. There's no such thing as perfect parents, because we cannot possibly grow up and not have to almost like rewrite and like almost kind of go over some of the things we learned as kids. And the reason for that is our brains are not developed when we're born, and then for a long time after that. So the way that we like the capacity we actually have to understand and interpret the world in a like cohesive, proper manner, we don't actually have that capacity, right? So like when you're little, an example, your parents tell you like, don't cross the street without holding my hand. Okay. Well, obviously that's what they're telling you because you can't understand. Don't cross the street unless you look both ways, make sure there's no cars coming or anything coming. And then you can decide, okay, now I can cross the street. Too nuanced, too gray area. Kids are black and white. Hold my hand. If you're holding my hand, cross. And I'm crossing, then cross. If not, we're not doing that. Right? But over time, you like update the information. And so there are things we do that with, right? But there's a lot of things that we don't do that with. And because we don't do those updates, we often stay in these very like immature and like inaccurate concepts of ourselves and the world, right? Another thing that happens is we don't necessarily even know that like our interpretations and our premises are a little faulty, right? And so then as we get older, we have these like misunderstandings of the nature of ourselves, our relationship with other people and the world. And then things seem more traumatizing and disturbing than they necessarily should be. But that's just because our premises and our understanding and expectations are a little bit off, but we just don't know they're off because that's all we've ever known. The other thing is, as kids, we are so narcissistic. That's it. We have to survive, right? As you grow up, you become ideally less self-involved, less the whole world revolves around me. This is why kids often think their parents, if they divorce, it's their fault, because literally everything is their fault.
Again, the world revolves around them.
Right.
Things that happen external to them are secondary to them.
So, and kids are so sensitive, right? We can't survive on our own as kids. And so we're therefore literally dependent upon our caretaker, whoever that is. Okay. And so I'm dependent upon my caretaker. And I also think that whatever's going on for them is my fault / responsibility. That's pretty heavy, right? Because they could be having an entirely like whatever bad day at work, their relationship, like if they're married, their marriage is bad. Like who literally knows? They could be just sick. And now I think it's my fault. So now everything bad that I think of as bad that's happening in the world, AKA with my caretaker, is my fault. And like let's say like they abandon me in some way, like either physically they actually leave, right? Or they're just like getting high, or they're drunk all the time, or they're at work all the time. Or this is even more confusing. They're physically there, but they have no ability to actually be emotionally present with me because they're just too wrapped up in their own lives, whether they're actually wrapped up in their own lives or they're too anxious or depressed or whatever it may be to actually be present. Either way, any of those things, I feel abandoned, right? Of course, I don't have the language for this, okay? But I feel like, oh, I'm not like safe and contained anymore, okay? I don't feel secure anymore. And I also don't feel accepted because if they're gone, like no one's there to accept me. But I need that acceptance in order to just like feel safe and okay in the world. I don't have this capacity as a child, right? And so now I'm alone and like misunderstood, abandoned, and like terrified. Why would that happen? Oh, there's something wrong with me. Because if there wasn't something wrong with me, then they wouldn't be doing that, right? And so now I have a lot of options. Either I'm going to fall apart at the seams because like there's something wrong with me, I'm going to give up. Or I'm going to be like, okay, this can't happen this way anymore. Now I'm responsible for everything. I'm going to be the one to fix mom. And sometimes parents put that actually on their kids. Sometimes they like actively. Sometimes that's just how the kid naturally, even if the parent didn't overtly say that, that's what they learn to take on. I'm now responsible for this. Either it's through overperforming or just in whatever capacity, right? Or I'm like not cared about by parents, but I want to be cared about and seen. If I'm doing well, they don't do anything. So now I'm just going to act out, right? And it's negative attention, but at least it's something, right? So there's all these different like conglomerations of ways that like we interpret what happens with our caretakers when we're young, right? And it can be very confusing because, you know, it can be very confusing because if our parents love us, right? They tell us they love us. Sometimes that doesn't happen. And that's also like heartbreaking. But let's say like our parents like love us. They'll like do whatever they say they'll do whatever they can for us, anything like that. That might be true, but they might not actually know how. They might not have the capacity themselves to be able to actually show up and be present in the way that I need. Right? And so that in and of itself is very confusing because it's like, well, if I were enough, then what they were doing, they love me. So why isn't that enough? But just not. Like objectively, that is not enough. Right? And so anyway, then we like think, okay, that reinforces that there's something wrong with me. Right? And the way that I cope with that is by like so strongly making sure that like that no one can ever say that about me, by like becoming like very successful in every single area of my life, right? Can't be a failure. Or I become just like so defensive that I just can't be a failure. Or I become super narcissistic because narcissism is really just a reflection of like deeply low self-esteem that I'm just like dedicated my life to avoiding, right? Or I just give up altogether, or I flip-flop between all of them, or I can't deal with any of this. So I'm just going to like get high or drink or like relationships and have fake relationship. Well, you might not think it's a fake relationship, but use interpersonal relationships to help me to feel better about myself in this like very cheap way because it's too much. I don't know how to do it for myself. I also never got it when I was a kid. This using you to help me to feel better about myself is the only thing that I know. Now I'm so dependent on you in a like unhealthy as an adult way to be dependent on you for my entire sense of self. You also have your own set of issues because if you didn't, you wouldn't be in a relationship with me who's using you for that only and doesn't actually care about you on a deeper level, right? I realize that people have a lot of like controversy about this, and I'm happy to have the debate, but just we're moving forward. And so now my entire life is built on these really like transactional relationships because I never knew how to actually feel okay myself. And it doesn't mean it's entirely like I'm feeling okay myself. Obviously other people are involved. It doesn't need to be pure independence, and interdependence is what's important. Right. And also people have to like earn the right to have that level of power in my life. Like if I'm going to like look to you for validation or approval in certain ways, then you should be someone who's worthy of like issuing that level of like validation and approval. Right. So there's just so many layers of dysfunction that can come from just like very simple, like everything looks great. But if I'm a kid and I don't have the ability to either be authentically myself and fully accepted, then like everything can kind of fall apart from there.
And here you can see the overlap or the cause and effect, how complex trauma, which is, you know, repetitive, emotionally traumatic, you know, things happening to someone, usually in relation to an attachment figure over a major developmental period of somebody's life that shapes the way that they relate to other people, that relate to themselves. And you also see the overlap with how this can lead to development of personality disorders, narcissism, for instance. So you've already touched on it, but a huge part of PTSD, complex PTSD, is the interference of having real, emotionally intimate, trusting, reciprocal, long-term relationships with other people.
Yes.
And this is what makes me really sad for a lot of my patients, is that it strips them of the greatest nourishment that humans need. It's connection to other people. We are relational animals. So here you've outlined some ways in which it interferes with the ability to relate and connect with other people. Now, how much of your work with complex PTSD has to do with sending them out in the world and having them actually relate and form relationships with other people, and then witnessing where things go awry, or where defenses or inauthenticity or fawning or people pleasing are getting in the way, or avoidance, for instance?
I mean, such a huge portion. It's
but
like,
is this part of the EMDR? Does this like
that's not part of EMDR. But that is like almost like when we're exploring and like figuring out how the trauma influences their life now. If we're not going through like a specific event or whatever it may be, right? Then it's more like my trauma is running my life. Now, it might be it's compartmentalized how it's running it. I might like if I I might have difficulty like with specific like figures, like authority figures or romantic relationships or just whatever it may be, right? So it might not be everywhere, but really the reality is okay, we were traumatized in relationship and we also have to heal in relationship.
Yeah. Now, complex PTSD in the context of forming romantic relationships. One example on how this shows up is this person has been emotionally traumatized by a prior toxic relationship. They trusted this person. There's a total violation and betrayal of trust. They were totally emotionally traumatized and heartbroken. And now they have this like complex post-traumatic stress from this long-term traumatic toxic relationship. One way this shows up is, and let's use PTSD language, right? As far as hyper-arousal and hypervigilance, is that they are completely afraid of building trust with another person because they want to prevent that heartache and that sort of betrayal again. And they have a total hyper-arousal. The radar is so sensitive that they're picking up on ways in which this person might hurt me.
Yes.
Even if it's a false positive.
Correct.
So and related to that is they cannot interpret and register safety signals that tells them actually this person is safe. An analogy I use with patients that have CPTSD, they have difficulty like trusting others and forming these types of bonds is, okay, let's say somebody walks through a dark alley, they get abused or raped or like totally violated. They will never walk through any alley ever again, even if there's safety signals, even if they're with people that that are protecting them, even if there's lights turned on, even if there's police, right? You have all of these safety signals that do not get interpreted or registered. And all they do is they see the potential threat, and that usually leads to avoidance.
Yes.
One of the ways that people engage in avoidance and romantic relationships is being emotionally guarded, right?
Yes.
They don't allow intimacy because now they are vulnerable to be hurt again.
Yes.
So CPTSD and romantic relationships is a huge topic that I talk about with a lot of my patients that have CPTSD. In fact, it's one of the most common topics of conversation with my CPTSD patients.
Right.
So what do you say? Like, what have you seen in CPTSD patients with romance? And what sort of advice do you have, actionable steps that can help them form these types of relationships?
So 2 things. One, that first relationship that you had, like that first romantic relationship you had that went awry and like heartbreaking, all of these things, I would argue that that actually wasn't the first like issue, I guess if you want to call it that. How did I end up in that situation really in the first place and not have like the proper support or proper like, you know, sense of self? So this is how I still go back to even parenting from when I was young. Okay.
Yeah.
This is just my perspective, but we won't go into that now. But yeah, I think unfortunately,
part of what we talked about at the beginning of the podcast were like the person themselves entering this traumatic experience has to do with whether or not it actually causes trauma.
Listen, I'll tell you, I hate the fact that I like so deeply believe in attachment theory because it's just, I'm not a big fan of being too therapist-y. Just like oftentimes is very like, just like a little mumbo jumbo kind of situation. But like legitimately attachment theory is like, like what can I do? Like our attachments from when we're young, like form, even like in the experiences we have in utero, like, and like what our mother's like stress levels, like it influences us. Like, sorry. And that's what all the research shows and what I've seen.
Well, it makes perfect sense, right? I mean,
So anyway, okay. So what can people do? Well, the first thing is, well, I have 2 things. One, let's go back to this analogy of you're walking in an alley, right? I mean, you might even know, like, okay, someone safe is with me and it's daytime and like, I know how to escape, like all of these things. You might even like be able to turn on the awareness of the safety things, but that doesn't mean it actually links to actually like, your body might still have the same response.
And your amygdala, your brain, your central nervous system, your automatic system.
100%. And then also then what next happens oftentimes is now I'm just really shameful and upset that although I'm aware that technically I'm safe, I don't feel that way at all. I feel so dysregulated. And now I feel not only dysregulated because literally that experience dysregulated me, but now I feel an overwhelming amount of like shame and like almost like anger at myself, like self-hatred type thing as a result of having this response. So, which is also makes it like worse. Then sometimes you can feel shameful about having that response. It's just like a cascade of just like shame, right? Again, back to the such importance on self-compassion. Okay. So, how do we navigate when that happens, right? When it happens that like, I'm aware that everything's okay, but I don't feel that way. This is where we get back to, it's so important to have good grounding skills because, and the only way, as obviously, you know, to regulate like our autonomic nervous system that we can physically do ourselves is breath work. Right. So, there's also like meditations and things you could do.
Is there a certain type of breath work that you recommend most for patients to self-regulate?
Whatever like feels comfortable for them. But as like a general rule, exhaling for longer than you're inhaling for allows, I forget what the exact like details of it are about why, but anyway, that is better than the exhale.
Expelling carbon dioxide. Kind of calibrating what like the O2, CO2 stuff. Yes, you're exactly right. Yeah. Physiologically there's.
There's different types of breathing techniques, like box breathing, or you can like inhale for 4 seconds and then hold for like 3 and then exhale for 6.
Which is, let me interrupt you, this goes back to what you said before. You want to do cognitive work with patients. You want to do somatic work with patients. Oftentimes when we're losing control of the body, it's difficult to gain control with the mind, with cognition. So we need to use physical tools, somatic tools, breathing being one of them, to calm the body so that the mind can actually start taking control. Which is where the breathing comes in. Because if you have dysregulated, shallow, frequent breathing, where you're not taking enough oxygen and there's too much carbon dioxide in your blood, it changes the chemical makeup that your brain is in, thus rendering you disabled to even get control of your body with your mind.
Right.
So you could talk your way through it. You could tell yourself this is safe. These are the safety behaviors, but still fail to get control of your body.
Yep.
Yeah.
And you'll learn for yourself what works for you. Sometimes like you can't still be in the same literal physical environment. You need to just like literally just like move rooms, whatever it may be. Other things like splashing cold water on your face, like taking a cold shower, like whatever. There's a variety of ways, but basically what's happening is we're interfacing with our physical system.
Mm-hmm.
Okay. So that's one thing. The other thing that I would tell these kinds of patients, back to the original question of like, if someone has CPTSD and difficulty in interpersonal, specifically romantic relationships, we want to do the math on the front end. If this person is worth, like, if I should take the risk, right? So of like, okay, I obviously think that everyone's unsafe. Okay, great. So I'm going to just cognitively do the math about if this person is safe enough. Mm-hmm. No one's going to be perfect. 1,000% in interpersonal relationships, I'm going to get hurt. Okay. Mm-hmm. It's just like what it means. Doesn't mean they intentionally mean to, but that is what it means to be like in an interpersonal relationship. Honestly, intrapersonal relationship. I hurt myself. You know what I mean? This is like what it means to be alive. Okay. So given that, what I'm going to do the math on, is this actually a safe person? Basically, it's not that there's not going to be any problems, but are we going to be able to work through problems and difficulties and fights in a way that actually is like healing?
Absolutely.
Right? That's real. Like, does this person have the capacity to do that with me? Do I have the capacity to do that? Are we both going to have to learn how to do that?
Yeah.
All fine. Mm-hmm. You know what I mean? But we have to know, like, it is, I think, valuable to do the math on the front end. And you can decide then, okay, I realize that this is going to be part of what like growing together and in building intimacy looks like. And I'm okay with that. Mm-hmm. You know?
Absolutely.
And that gives you a sense of like agency, right? Like I realize it's going to be scary and difficult in these ways, right? And also I know in this moment that I can get through it.
Mm-hmm. And this is where like the self-compassion comes in, but this is also where the acceptance comes in. And there's also a role here because I have patients that they're, doc, I'm dating this guy. I keep getting sort of like activated. I get ashamed. I avoid the date. I avoid him. What do you think about opening up with your romantic partner about the struggles that you're having rather than completely engaging in avoidance behavior because you're getting so worked up so often and also having shame that you're actually dealing with this post-traumatic stress? It can, like you said, the shame kind of builds up and again leads to avoidance behavior. I
mean, the partner, I think it's the respectful thing to do, actually, to loop my partner in, okay, to what's going on for me. Because if I'm like in a relationship with you, right, and now everything's great, and actually we had a great conversation. Now, as a result of this great conversation, I'm out. Like, absolutely not. That was way too vulnerable for me. I like literally want to poke my eyes out, run. Like if I could like just like never speak to you again, even though I actually really like you, that would be great.
Because now I'm at risk of being hurt.
Correct. I also am so confused because I actually really enjoyed that conversation, but now I like want to die. Mm-hmm. Number one, as a human being, if I don't understand what's going on, that's so confusing for me. I feel like literally psychotic. There's nothing wrong. It makes perfect sense. It obviously is not like healthy, right? But it makes perfect sense. I'm now at risk, okay? And I'm in a vulnerable position. Last time or a time that I was in a vulnerable position, all these other things happened. I like promised myself I'm never going to have that problem again. So now I have to like back all the way up.
Yeah.
Right. And even if I logically know you're safe, there's nothing wrong, blah, blah, blah. That doesn't mean my nervous system is catching up. It can take like days, weeks to like recalibrate.
Absolutely.
Now you on the other, first of all, the idea that I understand what's going on, like that'll be great. We need that to happen. That'll be amazing. But additionally, let's say I do understand, but I don't tell you. Poor you. You're just like, I don't understand. We just had a great conversation. I feel more connected to you than ever. You don't have the same trauma I have. You feel perfectly fine. And now I'm out.
Yeah. Now you're abandoning them.
Right.
Yeah.
And that's really obviously confusing.
You're perpetuating
and hurtful.
trauma, actually.
Yes.
Yeah.
And this is what happens in like so many codependent or just like not even codependent, just in relationships where people talk about anxious attachment, avoidant attachment, disorganized attachment, it like all feeds off of each other, right?
Mm-hmm.
Okay. So I'm not going to be able to magically not have this avoidant tendency. Okay. That'd be amazing, but this is not how it works. But what I can do is help you to understand what's going on and be like, listen, I'm not actually going anywhere. Although I like feel like I want to. I'm so terrified that this is what happened. I'm so terrified of this level of vulnerability and intimacy that I'm just like, my intuitive response is to just be terrified and I've got to go like away, just protect myself. I know that I don't actually have to, but that's what my like physiological response is.
Yeah.
And I'm like, I'm sorry because I want to be able to stay present with you, but I'm working towards being able to do that. In the meantime, this is what that looks like. And I promise you that after, like, I'll communicate to you when that's happening, right? And then I'll come back. And like, thank you for being patient with me while this is happening, whatever. Yeah. That way, even though it's inevitably going to still be hurtful for you, right? At least you're not like spiraling out. And I'll also learn as a result of you being patient and accepting or whatever your like healthy response is that, oh, actually I am not in danger. So you having a grounded, healthy, adapted response also helps me to not have this chaotic, spiraled out, like totally avoidant, though completely understandable response as well. And over time, the frequency of that need to run away, right? And the intensity of that need to run away will decrease.
Okay. That's important for everybody to hear. The intensity and frequency of this trauma response will diminish over time as your body learns that you are safe. You're actually revisiting this arc in which you're stuck in the fear and have no imagination or creative thought or like hope that there can be a safe landing. So you re-enter this sort of arc and you self-regulate and you increase your window and you expose yourself to the same threat that hurt you in the past. And over time, you realize and you pick up on the signals that this can actually have a safe conclusion or a safe outcome, which is by definition also what exposure therapy is.
Yes.
Yeah.
And there's no way to work through this without
courage, pain, distress, self-regulation, sleepless nights, anxiety.
Yeah, this is the thing.
The path of progress is a distressful and painful one.
It was actually one of my teachers told me this. He was helping me, obviously. When I was like working through trauma, you should expect that this is going to be extremely painful. And I was just like,
expectation setting up front. He's a good clinician. Yeah.
I was like, I know this. Like, I know this. But I'm just like, what? But having that, like, this is like, there's no way about it. Like, this is going to be difficult and miserable. And you're going to have to like build this resilience. And also you can do it, right? But to have this idea that it's just going to be blah, 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 easy peasy, like that's not going to happen. But you get to pick. You can either be like struggle with the trauma here and stay in it, but it's like the trauma and like the darkness, or you can work through it, which is also painful, whatever, but there's hope and freedom on this side.
Exactly.
And like, ultimately it is my whatever decision, but the idea that, I think working through attachment trauma is like some of the most, and CPTSD is some of the most, difficult, like, it's one of the most difficult things to navigate because it inevitably also does require you working through like addictions, eating disorders, like unhealthy relationships, porn, gambling, blah, blah, blah.
Of course.
So in healing this, I have to look at everything else.
Exactly. Yeah. So the question from the audience is, as far as like the CPTSD patient that's been emotionally traumatized and engaging in all this avoidance and totally afraid of being vulnerable for the fear of having emotional pain, whether that's being violated in some way, abused, abandoned, neglected. Do you have some advice as far as mate selection and what qualities to look for in someone that you actually choose to start dating?
Okay. Well, okay, one of my other teachers said this, which I think is fantastic. You know, if you don't have, it sounds very abrasive, but I'll explain. If you don't have any common sense, go find someone who does. Okay. So I have a bad picker, let's say. Okay. Great. I have to acknowledge that. And I'm going to share the information that I've gathered with someone who seems to have like a better understanding. Only caveat. Okay. So this is the thing that's difficult about outpatient therapy is the only reports that the clinician gets is from the patient.
Yeah.
And so there's going to be like a filter of some capacity, right? Just like.
Of course. It's
right?
completely
So
biased.
Correct. Thank you. A bias. So if you happen to also have people in your life that are, this is why like people have elders, okay? Because, and it shouldn't be our equals. We're all equally as like dumb as the next guy. But if we have like intelligent elders, right? Then hopefully we can share with them, right? Mentors, teachers, or like if you're able to give as least bias of a perspective as possible to your clinician or doctor, right? Then they can help you.
Life is not a one-person game.
No,
we're tribal animals, we're relational animals, and we're meant to rely on our tribe, our family. Yeah.
So we need to rely on our tribe for healing. We need to rely on our tribe for like even knowing how to heal, right? And it's hard to find a tribe when you feel so deeply alone. And the thing that's so hard is like what, almost like the result of the trauma, this like deep sense of shame and being alone and there's something wrong with me. And if people really knew this about me, like they'd leave or reject me or whatever it may be, or I'm going to be abandoned if I'm really myself and not doing all of these other things. Like those narratives are what keep us from actually being able to heal also. Yeah. So it's like, it's
such a fight. It's a fight between doing what you know to be right, doing what you know will avoid pain, and even if you know what is right, doing it despite your body alarm system going haywire and totally either putting you into a panic or shutting you down.
And man, that's so confusing because it's like, I feel so dysregulated and unsafe. So to not listen to that feels wrong.
You have to not listen to your body.
And then at the same time, you have to really listen to your body and ground yourself. It's just like this is why at the very beginning, I'm like, okay, healing trauma does require you to go to a certain level of maturity because they are such opposing beliefs that actually are both true, just in different contexts.
Absolutely. And speaking of opposing beliefs, kind of just a quick note on what you said before. As far as like, I need to trust this person and I need to recognize in a real mature relationship, good people can often hurt you inadvertently.
Yes.
Or even on purpose, good people can do bad things.
Totally.
That sort of like dialectic, that sort of DBT sort of education also has a role here in patients that have been emotionally traumatized and have difficulty trusting somebody else. And again, it's not just about them hurting me. It's about, oh my God, I have so shame about myself that if they actually know the real me, they will abandon me, right? Oh man, if you have the luxury of having someone as skilled as Sarah helping you through this, I really, really recommend finding a skilled provider because this stuff is so difficult to navigate. Your body's fighting against you. I really feel for all the traumatized patients out there because this is really tough. And then, I've had tons of patients say, hey, Dr. Mike, I'm doing my best. I'm in this healthy relationship. I'm checking myself. I'm using my skills. But my God, I'm in so much anxiety throughout the day. I have so much difficulty being present when I'm on the date. Even when we're not around, I have anxiety and insomnia at night. I'm doing everything I can. I'm meditating. I'm taking the medication. And still, making it through this relationship is so distressful. And this person, I actually have grown the trust for them. Yeah. But my body doesn't trust them. And sadly, I've had patients exit good relationships because they just cannot take the emotional and physical toll of the relationships, which makes me sad. Yeah. But there is hope. If you listen to this podcast and take away everything we're saying and you find the right provider, there's absolutely hope. People can heal from trauma. It doesn't mean that you're ever going to forget entirely what happened to you in the past. It's that you complete the arc.
Yes.
You can recognize that you'll be safe. You can self-regulate. You can widen your window. Will you be completely distress-free? No, no human is. And perhaps you have a little bit more distress than others, but you can retrain your nervous system. The brain changes that happen to you as part of PTSD can get rewired. The brain has neuroplasticity.
Yes.
We have evidence that these sort of changes can improve over time. And there is absolutely hope.
Yeah.
And I implore people that are traumatized to get the help, and healing is absolutely possible. I see it in my practice. Sarah sees it in her practice. We share patients. So I really implore people to get the help that they need.
Yeah. And the thing about this is it doesn't happen, unfortunately, especially with CPTSD. This like deep healing does not happen overnight or in like a couple of months. Listen, it took a long time to get to this place. It's going to take a minute to heal.
Absolutely.
And that is not a failure.
No.
You're retraining your body. It's like with any sport, you're not going to like in a month be an expert, right? And with this, because you're retraining your body, right? Or training your body a certain way. And in this, you're untraining certain things and retraining new things. It's actually a lot. Mm-hmm. And it's extremely difficult. It requires a significant level of emotional resilience. There's so many skills you have to build up in order to do that. The type of support you need to have any level of clarity. It's hard to like build a system that you trust that can do that. There's just a lot of layers. So being able to having this level of self-compassion while struggling. And listen, it sometimes looks like I made progress and then I like ran away, right? Or like, bailed. But I'm going to come back. I'm going to get up again. The real thing is like, I'm going to get up again. Mm-hmm. And that's not a failure and that you actually can do this. And if you don't believe in yourself, find someone else who does. And then until you start to believe in it yourself, obviously not in an unhealthy codependent way.
Of course.
Right.
Now, and if you want someone like Sarah in your tribe, right? So how do people reach you, Sarah? Like, where do they go? How do they get a hold of you?
Sure.
And Sarah runs her own individual practice, but owns a group and she can get you set up. How do people find Sarah? Sarah Burney.
They can go to BurneyTherapyGroup.com. I'm sure we'll also link just like the phone number and email.
We're going to link it all
in this. And then there's myself, and then there's also 3 other clinicians that also work at the practice. And, we want to see who's the best fit, right?
And you operate out of Orange County.
And we operate in person in Orange County. All of us do Zoom all over the state of California. I also see patients at this time on Zoom in Arizona, Oregon, and Pennsylvania.
Incredible.
Yeah.
Now, we thank Sarah Burney very much for coming. We're going to stay a little bit later and answer questions from the audience. We have a live audience today. And we thank everybody. Welcome, and thank you for tuning into Real Mental Health with Dr. Mike Ma. Thank you.
Oh, I cut you off.
That's good.